9:02, January 16th, Thursday. I know it's a Thursday today. Today we have with us kind of an introduction. Yesterday, we did introduction to, would somebody mind closing our door? Thank you. To sort of healthcare provider and system of care advocates. And today we are talking with patient advocates and starting with our chief patient advocate, Mike Fisher, joined by Emma Zabez in his office from the Office of the Healthcare Advocate. So
thank you.
Take it away.
Thank you. I think we'll just do a quick introductions of ourselves first, and then we'll give a presentation. And so,
hi,
this is Emma.
I'm Emma. As Melissa said, I am a health policy analyst on the policy team, Office of the Healthcare Advocate. So I work closely with Mike. I was also an advocate on the advocate team there for many years and worked for Vermonters, helping them with all kinds of problems navigating the healthcare maze that we have in our state. So that informs a lot of policy work. Thank you.
And I'm Mike Fisher, and yeah, I have this title, chief. I did want to just at least spend a minute of sort of recognizing this moment. I know almost all of you really well, but just to say out loud, I've been studying this process in this committee for a lot of years. And I think I've got it somewhat figured out, though it will still surprise me. But it's a human process, and it's often a complex mix of policy and human interaction. And I love it. And it drives me crazy. And I really wanted to just pause for a minute and say, I am happy to be a resource on multiple levels about policy and about the process of lawmaking. This table, the policy table and the policy committees, is where the real work happens. It's not at the press conference. It's not on the floor. It's not in the, in the back corner offices. It's here. And it's the process in these rooms, in this room, is precious. So I want to appreciate you all before you make the decisions I'm frustrated by. No. Okay.
I'm going to share the screen, see if this works.
Yeah. Great.
Right. Well, I think we covered the introductions.
Yes.
Go ahead.
So I'm just doing introductions for largely who our office is and a little bit about what we've done recently and then spending a little bit about some of its priorities for the session, but some of it's really sort of recognition of the challenges, honest recognition of the challenges in front of us. So there's the 15 of us. In that mix, well, there's the 15 of us. Just to recognize, we are defined in state statute, but we are through an RFP process, land at Vermont Legal Aid, and that makes us not a part of state government, independent, and I think people are sometimes confused about our role, that we're not a part of an insurance company, and that we're a resource available to all Vermonters. There's no income eligibility, and even the Vermonter piece, you have to have a link to Vermont. You have to. I mean, we get calls from Vermonters who are living in a different state and having Vermont insurance company and trying to maneuver, even our definition of Vermonter is somewhat flexible. Yes. Here, I'm speaking too much. You go.
We didn't coordinate who would do which slide, so it's on the fly.
I'm figuring it out.
So our office was established by the legislature here in 1998. So we've been around now for a couple decades. During that time, we have served over 70,000 Vermonters. And we have an advocacy team and a policy team, as we alluded to. Our policy team works to advocate on behalf of Vermonters through the legislature, with the Green Mountain Care Board, Department of Vermont Health Access, DEVA, we work very closely with, and the Department of Financial Regulation. We're essentially a watchdog, and so we are looking out for Vermonters' interests in the healthcare world. And then we have an advocacy team, and they are creative, brilliant, amazing problem solvers. They are like jacks of all trades. They know so much about so many healthcare programs. They advise, they advocate, they research, and we occasionally represent Vermonters too. So when somebody is just pulling their hair out and they cannot solve this problem on their own, we are the people who hopefully can cut through the red tape and get a resolution that works for folks. We'll talk a little bit more about how you're able to refer constituents to us if you get contacted with healthcare issues.
Well, let me just pause for a minute and say, I think we have a very good working relationship with state government. I think we work very closely, obviously, with the Green Mountain Care Board, and the Green Mountain Care Board staff. And we also work very closely with DEVA. With I think a strong relationship where we are supporting each other, and so I think it's important to, and I think recently with some of the concerns around insurance company solvency, I also feel like we've been working, had a strong relationship with DFR. But really, our job is to try and go anywhere where there's healthcare decisions being made, inside state government or out, and represent Vermonters' interests.
Do you, Mike, have any role within the Green Mountain Care Board? What do you?
So we have a statutory role in pretty much all of the regulatory processes. That role is a little bit different for the different hospital budgets versus insurance rate review or certificate of need or accountable care organizations. But yes, we have an official role representing the interests of Vermonters in those roles.
You have a seat at the table?
And we have a seat at the table.
Okay.
Again, the process is different for each of them, so it has a different feeling, but yes. You know what? That's perfect. Let me just recognize, Emma just some of the praises of the advocacy team. I want to pile on there for a minute. Today is January 16th. So yesterday was the end of open enrollment. And so this has been a busy season for us. And it is both, this is the end of the open enrollment period for the qualified health plans, but we've just been through the open enrollment periods for Medicare as well. And this was a hard year. And it was a hard year for us because it's a hard year for people. And so people call us with really complex problems. They're not quick fixes often. And also people call us at the end of their ropes.
Mm-hmm.
And so sometimes our job is to do our best to help people who are difficult to help. But they're difficult to help because they feel closed in. They feel like, maybe they're afraid of being able to afford the care they and their loved ones need, or maybe they're in pain themselves and feel really frustrated about this complex system not meeting their needs. And so our job is to show up and treat people with respect and care for them as best we can, even though the world feels really tough. And I guess I wanted to pause on that for a minute because I know you all represent the public. I think life is harder for people today. And so when we're trying to help them, or interact with them, we see that.
This is going to be a, maybe a controversial question, okay? And it's from personal experience. And before I ask this guy that question, we go way back together. This good relationship that you have with Diva,
Mhm.
do you see that relationship getting in the way when people come with complaints?
Actually, let me ask you, what's it like when we have a difference of opinion with Diva or with, on behalf of a person, a Vermonter?
Yeah, when we say we work really closely with them, we have an escalation path. So when Vermont Health Connect was first launched, similar to the governor's office, when legislators would get a call from a constituent who was just at the end of their rope, like, I have a family member, they need cancer treatment tomorrow, and my insurance was canceled for no reason. So we have an escalation path that kind of cuts right to the top. And so our relationship with Diva, I think, really benefits Vermonters in terms of, because you can spend a long time on customer service at a lower level where people are trying really hard, but they don't have the tools to figure out what's going on. And so I think our relationship with Diva primarily benefits people. I guess occasionally we have situations where we might disagree with Diva on the outcome of a case. And I guess all I can say is that we have a very good working relationship with them, and everyone's very respectful and rules-based.
Yeah.
So it always goes back to what are the rules that are, guiding the eligibility decisions.
I also think Diva understands our job is to advocate for the client and the client's interests. And so sometimes, we don't agree. And I think Diva understands that our job is to push back. I think also another detail in this is that we sometimes see patterns before they do about, like an error in a notice. And, this is a big complex system. And so we'll see a fact pattern repeat itself in 2 or 3 or 4 calls, and we'll say, something is amiss. And at least in my experience, when we report, hey, Diva, there's something going on here, they're very appreciative.
Yeah.
I'll also, this year in open enrollment, there was some I'm going to say explicitly because we're outside of open enrollment now. There was some communication to Vermonters that we thought was really important that Diva didn't believe that they had the ability to say. And that was to communicate clearly to Vermonters about the price difference between the two carriers.
Right.
And that price difference was really hard on a lot of very low income Vermonters for whom you would think we would have their backs with the premium tax credits and cost sharing subsidies. And so Diva recognized our role, and we worked together to attempt to communicate with that group of 6,000 Vermonters under 200% of poverty who were really exposed in a way none of us predicted this year.
I would just, I guess I'd call it a recommendation.
Mm-hmm.
In my constituent work, I'm hearing too much. They're in their back pocket.
Mm-hmm.
We're not going to get anything from them.
Mm-hmm.
And I know different personally. And I try to tell those people, look, that just is not something that is going to happen. And there's reasons for it. So I just let you know that there is some feeling out there that you're in Diva's back pocket. I'm just going to let you know that.
It's good to know.
Good to know. And I want to make sure that you all have my personal cell phone number so that you can communicate with me if there's ever anything that feels like it's going amiss. Or you ever want to let me know about a constituent who you think needs some
Yeah.
attention.
Thank you, Mike. Now it's
and-
out in the public.
Thank you for your advocacy around the exchange and choosing plans this year, because I noticed when I went to go re-enroll, it was very obvious what, a better choice would be. And so,
All right, we have a couple of case examples. Is that next?
Yeah. So I'll just say quickly, our advocacy team, they help with issues and go to this yet, right? No.
It's okay.
With access to care, eligibility for state and federal healthcare programs. We do lots of consumer education on all types of healthcare related topics. Billing problems, whether it's with a provider or the insurance, the interaction, healthcare complaints, and then everything related to buying insurance and financial health, as we talked about. And just again, our services are open to all Vermonters regardless of income. So we're going to share a few.
So
case
we want to
examples.
put this in the context of people. I think our job is to try and bring people to the table. And so these are sort of composite like stories of the kinds of cases that come through, a few of them.
Yeah. Woo. All right. So just to give you a flavor of the types of cases that we might work on or calls that we might get. So this, for example, and again, these are composites. This is Macy. Macy is 24 years old. So she's a household size of 1. She lives in Rutland County. And she just graduated from college. And she was on Medicaid during college. And she graduated and she just got a new job offer, which is awesome. She's going to be making $33,000, $975 per year. And she has an offer of employer insurance from her new employer. And so Macy is wondering, what should I do? I have Medicaid right now. I have this new offer of insurance. What do I qualify? What should I do? So our office would let Macy know, okay, based on that new income with your new job, you're going to be over income for Medicaid. But you do have a special enrollment to sign up for your employer insurance. So that means even if it's not open enrollment, which we were just talking about, which happens every fall, anytime you get the new job, new offer, you've got this. So she should sign up now. She should also report her new income to DEVA so that they can go through their system and say, okay, no more Medicaid, and send the termination and closure letter, which will be okay because she has employer insurance.
So this is a straightforward.
Yeah, this is a more straightforward one.
And, but I want to also recognize, because we live in these details, that is a straightforward one for us, but this one is one where people feel a lot of anxiety. Oh my God, how does this work? Is it going to work? And I've heard all kinds of horror stories of it not working.
Oh, definitely. And just getting out of college, being, suddenly feeling like, wow, I'm getting a job. I'm on my own. Like, what do I do? So we definitely get those calls. Okay, this next scenario, slightly more complicated. So this is the Rodriguez family. Alicia and David are married. They have 2 children, Frida and Amita. So they are a household size of 4 people. They live in Chittenden County. So Alicia and David make $86,000 per year. And Alicia has an offer of health insurance through her employer. So Alicia's, for coverage that would, health insurance through the employer that would cover Alicia only, it would be 6% per income. And that's considered affordable under the Affordable Care Act. In 2025, I believe it's 9.02% this year. So 6% is considered affordable. But if she put her whole family on the family plan through her employer, it would be 17% of their household income. The costs really jump. And so she is totally freaked out. And she calls us and says, well, can David, Frida, and Amita, can they sign up through Vermont Health Connect so that we can get more affordable insurance? Like, what do we do? We can't pay 17% of our income. So in this situation, an advocate from our team would give them advice. And just a little background, this situation is called the family glitch. And in the past, it meant that families could not get help paying for coverage on Vermont Health Connect. If it would block them all. But the rules changed at the federal level in 2023.
The Biden administration.
And there's the new rules now And the family members now could get help, financial help through Vermont Health Connect. So in this situation, we would say, Alicia, you should take the offer of employer insurance. It's considered affordable for you through the employer for the single offer. And that means you can't go on Vermont Health Connect yourself. But your spouse, David, can go on Vermont Health Connect, can get on a plan, he can get financial help. And your kids actually qualify for Dr. Dinosaur. And that's an awesome program that gives great health coverage to kids. And so they will be put onto Dr. D. So a lot of different programs going on with that one.
I recognize this was a problem for a long, long time,
It
and a
was,
lot of
yeah.
families were tied up in it.
All
and
over the
they
country.
would call us with such frustration, and I'm sure call you with such frustration. So this is a wonderful fix. It's not a perfect fix
Right.
to have families in two different plans.
Multiple plans, but at least they have.
So they would qualify for Dr. Dinosaur with the family household income, including the wife's
Yeah.
new job in this.
Yeah, so when they would screen them for Dr. Dinosaur, the state would still look at them as a household of 4. Even though Alicia's going on her employer insurance, they're still a household of 4 and they make $86,000. So they would run those numbers through the system. And we have a slightly higher eligibility level for kids and for pregnant people. The highest eligibility level is for kids. And that's why the kids would be found eligible for Dr. Dinosaur. But David, the spouse, is over as an adult and a non-pregnant person is over income. So he's in the Vermont Health Connect, the private insurance plan zone of coverage.
Okay.
Okay. Next, we have Cecilia. So Cecilia, she is 27 years old. She lives in Addison County. She would be considered a household size of 2 because she's pregnant. And so under the rules, we count the coming baby. Cecilia lives and works in Vermont. Her income right now is $3,000 a month. She recently found out she's pregnant and she wants to know more about her insurance options. How does she take care of herself? Make sure she gets what she needs when she's pregnant. She is undocumented. She calls us and says, how can I get healthcare? Can I sign up for insurance? So our HCA advocate would say, yes, it's a little bit complicated and we will give extra help and advice in these situations. But so Cecilia can sign up for the Immigrant Health Insurance Plan. This is a program that was created by the legislature a few years ago.
At this table.
Ooh, at this table that makes sure that all pregnant people, regardless of their documentation status, get the care they need and their kids. So she is income eligible for this program when we check the income numbers. She will also qualify for a federal program that's called Emergency Medicaid. And that exists everywhere around the country, and the federal government pays for labor and delivery. And so the state of Vermont loves it when you sign up for emergency Medicaid because it means we get some help with the payments. When Cecilia gives birth, her baby will qualify for Dr. Dinosaur, which is our Medicaid program for kids. And just to note that a lot of immigrants struggle to navigate this bureaucratic process of signing up. There's a lot of different programs going on. A lot of the notices that DIVA sends out are in English only. So if you speak any other language, you'll be getting notices where you're like, so it can be a very confusing process. And so we oftentimes will give extra help on these cases and help escalate them if they get sort of stuck and there's no response. Someone applies and there's no response and that type of thing.
So we're spending a lot of energy in this space.
We are.
This is an area, it's even this one is actually pretty straightforward. There's a lot of different immigration statuses and they have a lot of different, it's a complex, the world of healthcare policy and immigration policy, the interaction between the two is a really complex world where people need a lot of support to make it through. Big time.
Michael, after you go through this and you get this person taken care of, do you help her also with her to getting her immigration status straightened out?
We don't.
But do you?
We don't, but we would refer them to, so if they're having an immigration law issue, or they say like, I need to get this fixed, or I'm applying for this and my the status in my application is stuck, we can refer them to immigration attorneys and groups that can help.
You do that.
Yeah, we'll refer people. Yeah, we don't give the advice ourselves.
Yeah, good.
Yeah, yeah. Easy.
So we talk a lot about access to healthcare, and I think you just mentioned one that we don't talk about enough, and it's about access because of language barriers. What recommendations do you have for addressing that barrier that you just mentioned?
So we have attempted to model good practice here and put some effort into it. So HCA has, I don't even know how many languages we have our introductory materials in,
Maybe like 10.
or 14 or something.
14, yeah, we have a lot.
And so, we do our best to make sure our information is available to people in, even though there might not be a large population of people who speak a particular language, we're trying to do our best. And also have, translation lines to support people through the process.
And we have worked with DIVA to advocate for Spanish translations of applications, and they did implement the immigrant health insurance plan is translated into Spanish, the application for that. And the larger Medicaid application, the 202 AHMED, which is how you would apply for this emergency Medicaid program, was translated, I believe, last year. So there's a lot more work that could be done in terms of notices. But obviously computer systems, it's all pretty complicated to get that.
Do you work all with the Language Justice Project?
We do, yeah.
Actually, did our,
They do some great
Yeah,
stuff.
they did some videos for us.
Yeah.
And we have translator services. So if we have an advocate like that was working with Cecilia and Cecilia speaks another language, they would be working, our advocate would call a translator service and then call Cecilia. And if we thought, this client also needs something in writing, like maybe you're working with a client who has a memory problem and you think this person really needs this information in writing, we would send it to a translation company and we would have it translated in whatever language for the client and sent out so that they can refer.
and then the last thing to say in answer to your question, another thing that's important is reaching various populations. Like the right way to reach different populations is to reach out through organizations that have a relationship with them already. And so we do our best to partner with different organizations. We do, a member of our team, Alicia, does a number of clinics, family rooms. So there's
So there's a lot of new Americans, and we also work closely with Bridges to Health through the UVM extension, which works with a lot of farm workers and folks in other industries as well, the immigrants.
Thanks.
all right, one more.
One more, this is the last one. Okay, this is Jackson. Jackson is 67 years old. He lives on his own. He's a household size of one. He lives in Windham County. So Jackson is retired. He's living on his Social Security income. That is $1,650 a month. So he's been on Medicare for a couple of years now, and he is struggling to pay his healthcare costs on top of his rent and his groceries. We know that in this housing landscape, his rent could be like $1,500 easily. So his healthcare costs are quite a bit. His Medicare Part B outpatient insurance costs $185 each month in 2025. And his Medicare Part D prescription drug insurance costs $50.70 this month. That's an actual plan that's offered this year per month. When he goes to the doctor, he's paying 20% cost sharing for all the services, the doctor's appointments, labs, that kind of stuff. He's also paying the full cost of his prescriptions right now because it's January and he hasn't met his plan's deductible yet. And in 2025, most drug plans have a $590 deductible. So you have to pay out of pocket $590 towards your drugs before it even starts helping with anything. So Jackson is totally freaked out and costs are getting kind of out of control. He wonders if there's anything that can help lower his costs. So the advocate who would work with Jackson would say, yes, based on your income, you should apply for the Medicare Savings Program. We think that you would qualify for the QI1 level of that program. That program will pay your Part B outpatient insurance premium. That's $185 every month. So that's a huge help. And it's also automatically going to make him eligible for the federal low income subsidy program, which is all federal money, and it pays your prescription drug premium. And it's going to start with low copays immediately. It's okay that he's still in his deductible. And Mari, you want to ask a question now or right after?
Yeah.
Sure.
If that's okay.
Yeah, that's,
What's the difference between V Farm and LIS?
Yeah, so V Farm is
State.
is a state program.
Why would Jackson get LIS and not V Farm? And LIS sounds might be
LIS,
better because it covers the whole thing.
so LIS will lower your copays down to, I think it's $4 at the highest amount is $4 to $12 for copay. If Jackson had a lot of
$4 to $12 per prescription.
per prescription. So they're still a little bit high for somebody who's living on almost no money. So if Jackson had a lot of prescriptions, we might recommend that he should also apply for V Farm. And V Farm will lower your prescriptions down to $1 or $2. But for V Farm, you have to pay a premium to the state. So I don't know, Jackson, I haven't looked at Jackson's exact income, but the different levels for V Farm, the lowest income level, you pay $15 a month. Then it's $20, and the highest income level for V Farm would be you pay $50 to the state. So at the $50, if you're paying $50 to the state, your list copays would have to be, you'd have to have a lot of medications to say, oh, it's worth it for me to pay into that program. But it's a really great program.
And I think it's a great question because the policy area in this policy area is one that we're going to need to pay some attention to. And I think you just got a report yesterday about this policy area, about what to do with V Farm. And we've got a lot of feelings about it.
So to be continued.
Yeah. Madam Chair.
Madam
oh,
Chair.
I'm sorry. Sorry.
Committee's being very good.
No, I was looking for the report. I'm like, we get that report?
Okay, when people call you for help or information
Yeah.
and they tell you their income,
Yeah.
so you base everything on just their income and not maybe if they've got $500,000 in a 401k?
Only if we will be looking at the state rules for all the programs. So there is one type of Medicaid, or Medicaid for the age blind and disabled does have a resource test. And so it will look at your savings, checkings account, those kinds of things. So we'll talk to people about that because that would mean that they can't, if they had a lot of money, that would mean they couldn't
Okay.
get on.
And then the other major Medicaid
Major,
category
yeah.
is long-term care, which
Right.
also has an access test, but
Yeah, and
we
that's
don't
really
advise
cheap.
that.
Right, but we would send them to people who could give them advice
Okay,
on those.
okay.
Yeah, but so all of our advice is always based off the rules that exist and just trying to help people understand what those rules are.
And so then, thank you for the last bullet.
Okay, for the last bullet, this is like a thank you shout out to you all. So the HCA advocate would also tell Jackson that starting on January 1st, 2026, he is going to qualify for even more benefits thanks to the MSP expansion. You all passed an expansion of the Medicare Savings Program last year, which is great. And so for Jackson, it's going to mean that he will qualify for the most generous level of the Medicare Savings Program, QMB. That is going to bring his outpatient costs when he goes to the doctor down to $0, which means mostly federal money paying for his doctor services. And I will say the advocate team has talked to tons of people, and they are keeping a list of clients who call now who are not eligible for the Medicare Savings Program, but who will be eligible on January 1, 2026, so that we can do outreach and get them the help that they need as soon as it's available.
May I ask a question about that? Just because I love this program. I still love this program.
Puts you in a very small group of nerds.
I've never talked so much about Quimby and Slimby and QI and lists and so we made it January of 26. because we needed to get federal approval for the increased income levels. Has that happened?
We have chatted with Diva about it and we and they feel confident that it will be approved. You have to submit it in the quarter that the program starts, for the amendment. But those amendments under the previous Trump administration were, SAWs were approved and
State plan amendments.
State plan amendment, thank you. Like too many acronyms. And so they feel confident that it will be approved and they plan to start January 1st, 2026.
Great. Wendy, did you have a
Just a
question?
quick question, on the MSP, what did the percentage go up to?
Percentage.
145?
145 for QMB, and that is the 145% at federal poverty level, and that's the one that will pay the Part B premium and bring your cost down to zero when you go to the doctor, which is awesome. That's what Jackson will
That's
qualify for
awesome.
soon.
I love this program.
Yeah, it's a great program. And the high level, the QI1 level will go up to 195% FPL. And so that will help. It won't help with the cost sharing when you go to the doctor. You'll still have 20%, but it will help with your monthly Medicare premium, which is $185, which when you're living on just Social Security, that's a lot of money. It's very stressful for a lot of people. So yeah, and the QI1 is 100% federally funded. So that's really exciting for Vermont.
I think the next slide is going to.
Mari?
Go ahead.
This program was one of my favorite things on the campaign trail, or going door knocking and talking with constituents, in a time when healthcare is still really challenging and people are definitely struggling. It was nice to be able to say we were able to do this for this a significant group of people.
Yeah.
So it's one of my favorites as well. We as legislators refer our constituents to you a lot. You're probably the I make the most referrals probably to you,
Yeah.
out of
Mhm.
all the other agencies or organizations we could. You mentioned earlier, you get information specifically about this program. Is that confidential, or can you de-identify information and say there are Representative Cordes, there are 14 people in your district that benefited from this program? Can information come to us that way legally?
So this gives me, I think, the first thing to say here is that, so we keep data on every case. And people often ask me, like, how often does this happen or that happen? And I always need to say, of the universe of people in Vermont with a particular problem, how many know to call our office? Probably pretty small. So I think our data represents a canary in the coal mine like data more than actual data of the number of people who are. So I think I think due to the small numbers that we'd probably be talking about, it'd be hard for us to share number of cases in a district. We might be able to do number of cases in a county.
Yeah, that estimate is at least 12,000 Vermonters will become newly eligible for the Medicare Savings Program. So quick and dirty is you could divide that by the number of counties or by the percent of population that are in the areas that you represent, if you want to do a very de-identified high level estimate. But it could be something that you asked Diva for 1 year out, like in 2027, like how many new folks joined the Medicare Savings Program, and can you give us a map so that shows by county,
They would have to know that they could apply for this, right? It doesn't happen automatically.
Oh yeah, we will be gearing up with the agencies on aging and the SHIP counselors to get out the word.
It's going to be a big effort.
Oh yeah, it's on my to-do list starting this summer will be.
Which is another great partnership between you and us, because we as
Yeah.
legislators can use Frontport Forum and.
Oh yeah, we will
All the
be
tools to help you
shouting
get
from
that
the
out.
rooftops and definitely asking for your help in reaching Vermonters and your constituents.
So you you all help us so you've received various emails from me over the last, during the campaign and over the years. Often I will reach out to all legislators or all candidates and say, help us get the word out about something. But I think also there are lots of Vermonters who don't know where to turn. And, they don't know to call the Healthcare Advocates Office, or they don't even know to call DEVA, or, they just say, this isn't working, and they might call you. And so we want to serve those Vermonters because I'll just say, on average, I think the people who come to us through legislators are a little bit more desperate. They don't know where to turn. They're a little bit more frustrated with the system that they don't understand. And so so it's really the referral source through legislators is important. So we want to make sure that you guys know how to do it and how to communicate with other legislators about how to do it. We want it to be easy. There's no wrong door. The main thing that I wanted to emphasize here is that we need to have permission from your constituent for us to call. It's not uncommon that a legislator will send me an email and say, what do I do about this? And I'll say, ooh, you should refer this person to us. And the legislator's busy and they're not a caseworker and they got 10,000 things on their plate. And a week goes by and I'm like, hey, legislator, what happened to that person? Ooh, I got to reach out to them. And I end up feeling, so probably there's nothing I can do to fix this problem, but if the legislator says, hey, is it okay if I reach out to the Healthcare Advocates Office and make a referral? Then when the advocate calls them, they don't say, who gave you my number? We just want to make sure they know that it's okay with them for us to call them. And then all we need is their contact information as a brief little description of what's going on. And that can come as a direct appeal through me. And you can also give out the, for the constituent, I'd like you to give out the helpline number. But it's also perfectly okay to email me or to call me.
We have an online intake form. So if people are more comfortable with, on their cell phone or on their computer and they don't want to make the call, they can just fill out the form at our website. And you can also email the advocate team. You can, of course, email Mike, but you can email the advocate team directly, and whoever is on duty that day, checking voicemails, pulling messages, we'll make a case for them and make sure it gets to the queue immediately.
Do we run into any confidentiality problems?
Yeah.
With, okay. I want that to come out so people.
So it's a little confusing when you call and say, hey, can you work with this person? And then you call me a week later and say, how's it going? And I say, I can't really tell you.
Yeah.
We got to get permission from the person to keep you in the loop. And we will. If you say, hey, I want to track this, we'll ask the constituent if it's okay. And often,
Mostly they say yes.
well, they say yes. And often the information that the legislature is looking for is not the details of the case, but whether you made contact. And
Yeah. Wendy.
How does the Advantage plans fit into all of this?
so there's a rabbit hole that I think if it's okay, I think I'm gonna let's
Okay.
try and finish our presentation.
Sure.
And we can come back to that,
Okay.
or we can talk after, because it's a big topic.
Yeah.
I'm just recognizing the time.
Yeah.
And so this is a little, patting ourselves on the back and patting you on the back too. That advocacy team this past year saved Vermonters $3.6 million. How much? 3.6. And
That's a low estimate.
Yeah, the low estimate.
Not everybody remembers to enter the money.
last year, the HCA cost the state budget $1.8 million. So,
Could you say that again? I got distracted. by your-
$1.8 million was our budget, was our appropriation for our team last year. You increased it last year. Yes, I'm not asking for any more money this year. Our current budget is just over $2 million.
So 1.6 in the black, can we say that?
Well, just on the
Well,
first
to
line.
Vermonters,
The value estimated of the Medicare Savings Program that you helped us pass, that you were a key part in passing last year, has an estimated value of 48.1 million
wow, that's hard to believe.
Every
That's an
year.
incredible amount.
every year.
Yeah, the federal low-income subsidy program that you opened up, I mean, that's 100% federally funded. So you've expanded all these people who would qualify for that, pay that for their prescription drugs and co-pays. I mean, yeah. And then the QI1 level of the Medicare Savings Program is all federally funded, and the other sections have a match. So it's an amazing achievement. You brought a lot of resources to Vermonters to help them, folks with Medicare.
And then I'm not going to go into I tried to do the details the other day about exactly how this worked behind the scenes, but we've advocated for a number of years something on a silver loading strategy that is in place this year, that the board's actuaries, the Green Mountain Care Board's actuaries estimated the value of that was $40 million, all federal. Let's just, in full transparency, it cost us, this is from memory, something like $4.7 million last year to do the Medicare Savings Program.
Total.
The state budget cost something, you know, just so you can see both sides of the equation. So I don't know, is that 90?
It's close to 100 million.
Yeah, it really
Just
is.
under-
The policy changes are really significant. I mean, and the silver alignment took a lot of work, but it's just a policy change. And other states have implemented it, and yeah, it's incredible.
And then let me also say, you know, money is one way of measuring things. It's a sort of a factual way of, you know, Cecilia earlier, the person who was undocumented, who we might have helped, that she doesn't show up on here at all. So the human aspect is also super important. And
Yeah.
Thank you.
Thank you. Loved this. I always did this thing last year. If you give me $10 and I'll hand you $100 bill, what deal are you going to take? That's kind of what we did.
I'm not going to spend any time on these really. I just wanted so we have a bill that's being introduced by Representative Cordes and maybe others to update our statute really significantly, to bring our statute into line with our practice, with a few other changes. We look forward to a real conversation about how to move forward on provider rate setting, often referred to as reference-based pricing. This year, we think it's important. We've been a part of working on a private equity regulation bill that we support. You just got a report yesterday about Medicaid dental, and we have been a long-term advocate of removing the dental cap for adults. The dental cap for children there is no dental cap for children.
And that's for Medicaid.
Yes,
We did raise the
Yeah.
dental cap.
we did.
Yeah.
We raised the rates and
And the cap.
and put the cap in, and then we fought to have this report come back to you. So that's finally here. And we wouldn't be the HCA if we didn't keep advocating for improving the Medicare Savings Program. So we'll continue to advocate for that. Is there anything else to say about that one?
I guess I'll just say real quickly, so that as DIVA and we were looking at the amazing expansion that you all passed, bringing the Quimby level to 145% FPL, we realized that it would be very efficient and smart for the state to bring it to 150% FPL, because there are federal requirements that DIVA process federal leads data. So the low-income subsidy, people can apply for that separately through the federal government. And the federal government sends that to every state Medicaid office. And you have to process that information and check if they're eligible for programs. So if QMB was at 150 and the list data coming in was at 150, Diva could just put those people on QMB and it would eliminate a lot of work. But with QMB at 145 and the leads data coming in at 150, they'll have to check every single one. So it just means that it's more burdensome for the system. So it's something to consider. It would be a small increase. And we can certainly revisit that and talk more about it later this section. But it's just like a system efficiency to consider.
Do you have any idea what the general fund dollar on that would be?
No, we have not done that yet. So happy to look into that. That's a great next step. Yeah, we're just sort of realizing like, oh, so we will get back to you all on that for sure. No way you can help with.
Diva, yeah. Diva.
Yeah.
So, and then the last thing I wanted to talk, you spent yesterday hearing from providers about the crisis, the healthcare financing system crisis from their perspective. And I guess I wanted to recognize that same crisis is showing up, I think we know, from consumers and from people who purchase insurance, small businesses, large businesses, self-funded businesses who buy through the self-funded market. Everywhere we turn, we're hearing people express experience a crisis around the cost of our system.
And the impact on property taxes.
The taxpayer, thank you, experiences the same thing for public employees. And also people who are getting Medicare supplemental plans experiencing a 40% rate increase is not unheard of. It is the crisis showing up all over the place. The one thing that hasn't been talked in here yet about is the challenge that this is having on our carriers. Insurance companies, I think, are showing that you received a letter from Blue Cross yesterday. Both sides that they're okay, but also that this is that the costs of this system are a real crisis for ratepayers.
I didn't see a
I'm
letter.
sorry, we didn't
get it.
see a letter from Blue Cross. Maybe Blue Cross could send us a letter.
Forward.
Yesterday or the day before?
Don George.
Don Jones?
Yeah, I got one.
No,
Yeah.
I didn't get it.
I think.
Yes, so make sure you.
Maybe it went to spam.
Maybe it went to spam. We all got it.
Oh.
Yeah, okay,
I forwarded it to everybody.
Yeah. And I also, a month ago, Blue Cross sent out a press release about a downgrade in their rating, in their bond rating. So I really wanted to put on the table that this system is in crisis. I have a little flashback to a moment when I sat at the other end of the table in the other room, and we were talking about how we could possibly finance taxpayer financed healthcare, and people were saying, "How could we possibly pay for this?" And part of the answer at that time was, "Well, we can't pay for what we're doing." And for the last 10 years, our office has been saying, we're really driving towards a cliff here. This system is unsustainable and it will crash. I fear that we are really on the precipice of that. That in the coming days and weeks, we will see key parts of our healthcare system show up in more than just stress that are really in trouble. And it really boils down to the prices we pay at the hospitals. And we spend a lot on our healthcare in Vermont, and no one's going to rescue us. There's no big magic pot of federal money that's coming in the door. There's no viability, in my opinion, that the legislature can go to the taxpayer and ask for more money for this system. We're sort of stuck with what we have. And I want to mention the only entity I know of who's doing well right now is UVM. UVM Health Network. UVM Health Network reported to the Green Mountain Care Board of $100 million surplus this past year. And UVM Health Network obligated group reported to the bond services agencies last year that they had a profit of $241 million last year. Now, I want to recognize that I use the word profit, and there's people on YouTube who are yelling at me right now. Wait a minute, we have a nonprofit system. And so I'll correct myself and say revenues in excess of net of expenditures. That's the meaning of the word profit. I'm not talking about a tax category here.
Shareholder, yeah.
I'm not talking about the IRS status here. I'm talking about bringing in more money than they had to spend in order to deliver the care. And these things are related. The challenges in segments of our healthcare system that don't have enough money coming in to make it, and the challenges that the ratepayer are experiencing. And by the way, we can't do another 20% rate increase this summer. And guess what? I'm expecting a 20% rate increase. And the horrible challenge of the carriers saying, if you want us to continue with any kind of solvency, we need this. I know that it's easy to blame the big bad insurance company here, and I can be all kinds of critical about decisions that our insurance companies have made. But in my opinion, what is going on right now is the cost of care and the prices of care at Vermont hospitals, particularly our largest hospital.
I want to be respectful of Mike's time because I know he has a bit of a hard stop. But Leslie, you had a question, but is it a really quick question?
We don't have hard. We have 15 minutes.
Oh, I thought you had to be done by 10.
10:15, we're supposed to be in Senate Health and Welfare. They gave us 15 minutes to do this, so you guys got the.
It's going to take you 15 minutes to get down there and answer all your text messages that you're probably getting right now for what you just said. Alan, can Leslie ask her question real quick? I'm sorry.
My question is pie in the sky.
Yeah.
Vermont is the size of a medium-sized city. But yet we're expected to do everything that all states do. And I find that really ridiculous. So I'm trying to sort of come to some reconciliation there. And I was just wondering if you have any thoughts about that. And I'm also wondering, are there other alternatives like connecting with other states around us? Why would they care? Why would they want us? We have an older population, probably ridiculous. But I'm just trying to think of other ways that we can move through this.
Was it you, Madam Chair, that I said this to the other day, that Vermont has East Coast liberal state aspirations and deep South finances. Maybe it's not as bad as that, but I've had that thought for a long time.
We're a receiving state anyway.
Yeah. I don't know. I mean, I think the prospect of joining with another state is
untenable. I get it.
It's got a lot of challenges.
Yeah, I can't see why they would want us, but I don't know any way around. I mean, like you say, we are at this place. What is a possible path?
Yeah.
I mean, is there a legislative, opportunity, or do we just wait and see how things fold and you're going to fix it?
Well, no.
Yeah, you.
That's my question. How are you going to fix that?
Provider rate setting. Again, people are using the term reference-based pricing, and there's this proposal out on the table for public employees to get a reference-based pricing. The tool of provider rate setting for the whole market feels like a necessary tool. If we want to do a better job of making sure the money goes to the right places, to the primary care, to the clinics, if we want to be able to get the money to parts of the system that we need to make sure is standing up, And we want to right price other parts of the system. I know it's scary.
Because we've already seen one bankruptcy and, well, and that's in my territory, so I'm very aware of it. And, I'm worried. I mean, and I'm just trying to, yes, we can nibble around the edges, which, you know, that's great. And we help individuals and that's also great, but there's not a systemic, or I'm not hearing yet.
And, you know, the other thing that I meant to say earlier that I just want to mention, what I heard out of the Bruce Hammery report was our system is in crisis. And if we don't do something about it, we'll see closures of hospitals and health parts of our healthcare system. I wish that Representative Page was here because I wanted to say to him, I know it's scary to see your hospital identified as a place where there needs to be real change. We were never in support of the details that were in the Hammer report, but I was very much in support of the overall message. We have to take action. I feel very frustrated by the hospital association for, their response was to shoot at the data and say there were deficiencies in the data. Guess what? Healthcare's got more data than you can imagine, and there's a problem with all of it. And if you want to discredit it, somebody will discredit it.
But it doesn't change the outcome.
But it doesn't change the overall.
Because we're not changing our system, the process, our system, whatever. That's what's driving me crazy. I'm really struggling because the Hammery report, if I may, came out and it was like shoot Hammery, shoot the Green Mountain Care Board. Okay, but that doesn't change the fact that Springfield Hospital went bankrupt and there are 9 out of 13 on the edge. So what do we do? We could be mad at them, but how does that change anything?
I used to put affirmations on a 3x5 card on my bathroom mirror. And the sad part is now currently I have the definition of economics. And what is economics? It's the allocation. No, well, it's the allocation of scarce resources.
Mhm.
I think that's what we're looking at, in what you're saying. We have scarce resources. And I think what the report does is it imagines us how we're going to allocate those scarce resources. Alan had a question.
I'll hold off on that.
Mari had a question, and then I see Daisy.
It's more of a comment in this realm. We haven't talked about a huge part of the problem that we're in is something that has to change in the federal level because Vermont is so small and we don't have the tax base and the resources to address these huge problems. And pharma is a big part of that. And we need real federal action. The work on PBMs is too little, too late. Anyway, I'm not going to go down the PBM road, but prescription drug prices are a huge reason that health insurance costs are going up so much, and the outsized control that the pharmaceutical industry has and the whole market chain is driving that. And it's outrageous that it makes me really mad. And the other thing is, I agree with the comments about whatever you think about the data from the Oliver Wyman report. Yes, something we need to do. We need to act, and we need to act collectively. I too was very frustrated. I'm an employee of UVM Medical Center. I love working there. I love my job. There are a lot of great people there. I'm really proud of the institution, and I was really upset with their response. Just the manner of it. If we're in a plane that's crashing, we need people to be working together, not having inflammatory reactions. And it's understandable. I get it. It's very it's scary to think about what we can and might very well lose in our healthcare system. But that's why I asked the question the other day, I don't remember to whom, about where is that table with all the grownups in it? We need that table, instead of different parts of our healthcare system, shooting fire at one another. We need to have coordinated control, understanding the severity of the crisis and being willing to make sacrifices, and change. That's what I want to see. And I think we can do that, but it's gonna take some real effort.
Recognizing the time, Daisy is gonna, last question, and I know Mike has his ever helpful green sheet with, so if you could pass those out. And I also noticed that you have a little stack of cards, and I'm hoping those are your office cards. I carry one in my wallet.
So this is my card. It also has the office's number.
Oh, yeah.
It also has something that's called direct line on here. Never call that number. Call myself on. Anybody need this?
I'm just gonna attach it to this.
So,
I'm good.
so I just wanted to say, first of all, Mari, excellent comment, and I think this table is the table.
Oh, can I, before I forget, can I, so there's a blue one on there. I try and change the color every time I hand it out. The blue ones are outdated.
Does that mean you want me to replace this?
And in the left, I don't know whether you need one. Do you collect paper anymore? Anyway, and this has the date right on the top of it. It's gonna be out of date in March. And
Bring a new one.
we'll bring you a new one.
Don't change anything in the next couple of weeks, because then they'll have to do a whole new one.
You pass those cards out, Mike.
Yeah, I mean, who needs a card?
Probably should. I'll put one
I
on.
was hoping that you'd have one in your Vermont Legal Aid office that has the number
We'll
constituents.
bring you a stack of those
You
cards.
see that one on BT Health though or something?
Oh my gosh, I didn't realize that it had,
Is it something like that, or that could be affiliated, but I have a cool acronym.
thank you. Thanks so much for coming in. Thank you for the work you do, on behalf of Vermonters. And we're gonna take a break right now, so if we want to go off of
Thank you.
live.
You all too.